social prescribing at CCHOHT, and a hospitalist working at Oakville Trafalgar Memorial Hospital. I'm excited to welcome you today to the Lifestyle Medicine Social Prescribing webinar, the first one of 2026. This is a bi-monthly webinar initiative designed to support all of us in primary care with evidence-based practical approaches to incorporating lifestyle medicine into our practice while addressing social aspects of caring for our patients. Today's session, the Chronic Pain Reset Button, reframes chronic pain as a biopsychosocial condition shaped by modifiable behaviors. Dr. Rhythm Gumber will share practical lifestyle reset strategies to help us confidently use evidence-based, non-pharmacologic approaches in practice. We're thrilled to have him here with us today. Dr. Gumber is a mindful and innovative family physician with a focused practice in hospital medicine, pain, and MSK medicine. Dr. Gumber completed his residency in family medicine at the University of Manitoba. He also finished 1,600 hours of preceptor-guided training in interventional pain required for change of scope of practice under CPSO. He currently works as a staff hospitalist at Oakville Hospital, as well as a pain MSK medicine consultant at the Burlington Pain Care Clinic and Anthrobiologics Orthopedic Clinic. And he is also an associate professor at McMaster University. Being an active advocate for chronic pain management, Dr. Gumber has taken extra training in the field of pain medicine from Harvard, U of T, and McMaster University. He holds a Master's of Science in Pain Medicine at the University of Edinburgh, and he is currently enrolled in the MSK Medicine postgraduate certificate course at University of Leeds. He has a special interest in management of neck pain, back pain, osteoarthritis, headache disorders, fibromyalgia, neuropathic pain, and MSK-related painful conditions. He uses various strategies such as ultrasound-guided interventional approaches, multimodal analgesia, intranasal ketamine-based protocols, neurofunctional acupuncture, and mindfulness-based chronic pain management in a multidisciplinary team-based environment under biopsychosocial model of care. Welcome, Dr. Gumber. It's a pleasure having such an expert here with us. So before I turn it over to you, just a few housekeeping points for everyone here. It would be great if you could kindly mute yourself so we minimize background noise. And I'd ask that you kindly add your questions to the chat or ask questions at the end. There will be a brief evaluation form in the chat as well, and we would love if you could fill that out as well. Thanks again, and I'll turn it over to Dr. Gumber.
Thank you, Nidhi, for the introduction, and hello, everyone. Good afternoon. So I'm Rhythm, and today I thought we'll just talk about the chronic pain reset button. I must confess, chronic pain is pretty challenging for myself as well. The more I'm learning, the more I realize I know less about chronic pain and patients suffering from chronic pain. So I also want to confess that most of my practice over the last few years have been around interventions and pharmacotherapy, but I've come to realize that if lifestyle interventions are not incorporated, there's lack of success, there's lack of rehabilitation, and there's lack of long-term benefits that we get from the multimodal and the interdisciplinary approaches. So just gonna see if I can navigate through this. So I think Nidhi already mentioned I work as a hospitalist in Oakville Hospital, and then I do pain medicine, chronic pain medicine at Burlington Pain Care, and I do a little bit of MSK medicine at Arthrobiologics. So I have no conflict of interest today, and jumping on to learning objectives. So I guess the first step would be to understand chronic pain under the lens of the biopsychosocial model. I think acute pain still come under the biological process, but to understand chronic pain, there has to be a psychological and social variables which drives the prevalence and experience of chronic pain. We'll try to review some evidence-based lifestyle interventions for chronic mechanical lower back pain, which I believe is the most common back presentation one can see in primary care. And I'm cultivating special interest in fibromyalgia, so I thought of discussing some lifestyle interventions I'm experimenting with my patients with fibromyalgia. And we'll try to go through some of the ideas that we could incorporate as primary care practitioners in the form of a prescription format of these lifestyle interventions to have more adherence and compliance for our patients. So, um, just going on the definition of chronic pain, as per International Association of Study of Pain, any pain that persists or reoccurring for more than 3 months can come under the category of chronic pain. It is not just a sensory experience, it's both sensory and emotional experience, and hence the importance of biopsychosocial model. You need not to have a tissue damage to qualify for chronic pain, because many times the pain will persist despite the normal tissue healing time. And as mentioned before, it's best understood using the biopsychosocial framework. So there is a biology component to the chronic pain, which is nociceptive, which is tissue injury, or neuropathic, which is neuropathic injury. But then, because of being in the chronic pain, because of the mental health factors, our patients can acquire dysfunctional chronic pain behaviors, or such as kinesiophobia, fear avoidance behavior that can also propagate a chronic pain state. And of course, there could be social factors, work-related stress, or the kind of work. So, in summary, you try to look at the whole biopsychosocial model. Um, I think before studying chronic pain, I must confess I was, had this thought of judging behavior towards our patients, that you don't have a tissue injury or a nerve injury, why are you still in pain? But now I've come to realize that when a patient comes with a painful condition, their pain is real no matter what. That's the first take home I take for myself. The second is the important question: where is the pain coming from? Is it the biological reason, or there is the psychosocial drivers for the pain? I have to quickly divide the pain into three categories. One would be the most common would be the nociceptive, which correlate to the tissue injury. Example could be, inflammation, fractures, burns, or any kind of a trauma related non-neuropathic tissue injury. The other would be the neuropathic, which could affect the nerves either at the peripheral level, or at the spinal level, or at the central level, and it could range from radiculopathy, diabetic neuropathy, trigeminal neuralgia, post-thalamic stroke-related pain, or various radiculopathy or myelopathic conditions. The third one is an overlap of both of these conditions, which is primarily of my interest, and because that manifests more as chronic pain. Um, so that would be nausiplastic, and it also correlates to another medical term called peripheral or central sensitization. To explain this further, let's go on this picture. So, for example, if I go back to the nociceptive pain, that would be from the tissue injury from various triggers. The neuropathic could involve the nerve injury either at the peripheral level, or at the central or the spinal level, or at the central level. Um, the the third kind of pain, nausoplastic pain, does not correlate to an ongoing active neuropathic or tissue injury. It could be associated with it, but it's normally could be related to the wind-up phenomenon, which means that the pain pathway is overactivated. So these fibers are overfiring. Um, the spinothalamic tract that goes up to the thalamus could be overfiring. The thalamus, the somatosensory cortex, which gives the sensory experience of pain, the prefrontal cortex, which will give us the emotional experience of pain, they could be overactivated. For example, if we take these patients, for example, fibromyalgia or CRPS, or patients with central sensitization pain syndromes, and we hypothetically do a functional MRI, these areas could light up. The other, sometimes we see this descending pathway, which has a neuromodulating effect on chronic pain. So it's supposed to downregulate the painful stimuli. Sometimes it becomes disactivated, and that could also lead to that overall wind-up phenomena. These patients could have features of widespread pain that you can see in fibromyalgia. They could have features of hyperalgesia or allodynia. And since it could be a central problem, there could be associated chronic fatigue. There could be overactivated sympathetic nervous system. Um, there could be sleep irregularities. So it comes with a whole spectrum and hence chronic pain syndrome like presentation. So I wanted to discuss about those mechanisms because they might be relevant to our cases. So the two cases that we will discuss, one would be the mechanical lower back pain, but this is a chronic mechanical lower back pain with a tinge of sensitizing features. So let's go to case number one. So this is a case about a 38 years old male who came to our clinic with 6 weeks history of right leg dominant lower back pain. He had background of intermittent mechanical lower back pain that dates back to 10 years, which is likely relevant to his contact sports. He was active in playing ice hockey, basketball, so lots of sports injuries. He had his ACL repaired a few years ago. He was working full time as a go bus driver, and because of his pain, he was having ongoing interference with his work, and hence he had to go on short-term disability. When I saw him, the initial presumptive diagnosis was, well, he has a mechanical lower back pain, but it was not just back dominant, it was also leg dominant, and clinical presentation pointed towards right-sided L5 radicular features. This pain was going on for a while. He had seen his primary care practitioner. The initial imaging was not very concerning. He had been doing some physiotherapy and home exercises, but not very wholeheartedly in the community. And I think he was also started on low dose pregabalin by his primary care practitioner. Um, of course, the pain was interfering with his work and daily activities. He has also developed some kinesiophobia and some fear avoidance. He was having his family doing some like his daily chores in regards to snow shoveling, taking the garbage out. So there was some beginning of to develop some pain related behaviors. So we went on with an MRI of lumbar spine as it had been more than 6 weeks. His MRI was significant. There was posterior lateral L4 L5 disc herniation with confirmed compression of the traversing right L5 nerve root. Um, so his diagnosis fits the category of leg dominant back pain with right-sided L5 radiculopathy in a background of underlying chronic mechanical lower back pain. We rule out red flags in context of neoplastic, inflammatory, infectious, or traumatic etiology. This is a good slide I normally use when I have patients for back pain. It's helpful to differentiate between back dominant and leg dominant. Back dominant would narrow down the differential diagnosis to discogenic or facetogenic, and based on flexion abnormalities and extension abnormalities, you could further differentiate to discogenic versus facetogenic being more extension only. Leg dominant would qualify as radiculopathy or spinal stenosis. And based on classic features of spinal stenosis, pain worse on walking and standing, and relieved on flexion, they kind of help you to differentiate. And if you're having mixed criteria or neither of these criteria are making sense, then or the pain is chronic and you're noticing that the lumbosacral spread of the pain is increasing and they're having features of hyperalgesia, allodynia, excuse me, then it could point towards non-mechanical pain with or without sensitizing features. It's important to rule out yellow flags in context of dysfunctional pain behaviors, opioid overuse, or any untreated mental health condition. Then, of course, ruling out progressive myelopathy or cauda equina or cystic inflammatory arthritis screen in selective patients at certain age groups. So the management strategies for chronic back pain with or without leg symptoms revolves around education and reassurance, lifestyle-centered non-pharmacological care, which we'll discuss in more detail today. I think the pharmacotherapy and interventional therapies are the most common, like go-to, and then there's a role of multidisciplinary coordination. Um, as I mentioned, most times I would lean on pharmacotherapy and interventional therapy. I would tell my patients, my goal is to decrease your pain with medications and injections, and then you'd see a physiotherapist. They will do the rest, and I will give them a blanket prescription to see the physiotherapist. Um, and just before jumping on to the physiotherapy part, just quickly going through some of the multimodal analgesic options would be the non-opioid options such as Tylenol, NSAIDs, Lyrica, gabapentin, duloxetine, and tricyclic antidepressants. In this patient, I upped his Lyrica. We went to 75 BID. I had given him PRN dosing for NSAID and a muscle relaxant for episodic pain relief. Um, Thankfully, his symptoms were not severe enough to consider opioid interventions, which is normally discouraged. But for some patients, once they have failed the non-opioid, then they can be used cautiously. Um, we did perform some interventions for him. So I performed ultrasound guided selective nerve root injection along with caudal epidural for his myofascial component. We performed paravertebral and ESP block, which would be recti spiny plane block, um, which can help for mechanical and also for, to some extent, for neuropathic back pain. These are low risk procedures which can be performed in an outpatient setup with but if a patient needs like an advanced transforaminal or translaminar epidural injection, then these are normally referred to a pain specialist with anesthesiology or fluoroscopy background or a neurosurgeon. I do like to perform acupuncture for my patients. So I did perform neurofunctional acupuncture on him for 6 sessions, and he did notice surprisingly 90% improvement in his radicular symptoms. So I was like, wow, we made some improvement. So there was improvement in his leg symptoms. However, he continued to have lower back pain. I did not make any improvement in his evolving pain-focused behaviors. His mobility was still poor, and even though I initiated discussions regarding going back to work, he was still he was still reluctant to go back to full driving. And there has been a good study about disability and back pain. So if normally a patient misses work for 3 months, they have a 50% or less probability of going back to work in the long run. And if they miss their work for 6 months, then this goes down to 25%. And if they miss their work for 1 year, then their probability of going back to work go down by 3%. So most of the time, the patients we see in our pain clinic, they have either been on disability or they have been on pain for more than 3 months. There are some challenges that come across to rehabilitate them. But what I've noticed is the patients who are able to go back to work and reclaim their life, they are the one who do the best when it comes to overall chronic pain management. For our this fellow, he was requesting neurosurgical consult, so we referred him to Trillium Spine. He was seen in Mississauga. However, because his leg dominant symptoms had improved, the neurosurgeon rightfully decided not to perform a surgical intervention and advised him to continue with rehabilitative measures. And probably if his leg symptoms resurfaced, then he could be a candidate, but he was a young guy and his leg symptoms had improved. So I think he was a bit reluctant to go with the neurosurgical options. So we did had some improvement, but there's lack of rehabilitation. There is ongoing evolution of pain, dysfunctional pain behaviors. So what could be missing here? And there where I feel was an immense role of lifestyle interventions, and that starts with patient education. I think the biggest message that we can give to our patients who come with chronic pain is setting realistic expectation. I always tell them that if I will make your pain disappear, then if I say that, then you should run because that's the biggest lie. My main goal is to reduce your chronic pain, and a realistic goal can be 30% or plus pain reduction. But more importantly, it's functional restoration and encouraging you to reclaim your life, going back to work, um, reclaiming a sense of purpose and trying to shift from a pain centered life to a function centered a life with more fulfillment. I try my best to explain chronic pain mechanisms um, through audio visual aids. And I keep on repeating them on multiple visits so that they can have some sort of understanding, um, and also reinforcing realistic expectation and having an early discussion regarding return to work and a gradual return to work and reclaiming their life. So the best treatment so far for mechanical chronic back pain with or without sensitizations, and even for non-mechanical back pain, is exercise-based therapy. There is for mechanical back pain, there has been good um, evidence on Pilates-based core stabilization and McKenzie directional exercises, which we'll discuss. Realistically, in the past, I would just give them a physiotherapist guided prescription with a very blanket statement: back pain, see physiotherapy, and that's it. But um, I think patients do better if they are given some sense of control by providing them resources in the clinic when they're seeing us and reinforcing them from time to time during their regular visits. So let's briefly touch base why exercises works in chronic lower back pain. So the biggest advantage, it addresses deconditioning, especially in patients who have pain for more for some time. Um, the exercises which are tailored in a graduated fashion can reduce fear avoidance behaviors, and it empowers them. It empowers them because 90% of us will have back pain throughout our life, and 90% of these patients will have mechanical. But the good thing is that 90% of the time the pain will self-resolve, and the pain can reoccur. So if they have a set of tools that they can use, that it helps them for the long-term functional outcomes. There is good evidence on exercises, reinforcing education on exercises, and just by motivational interviewing, self-reflection, behavioral therapy as first line, Pilates and McKenzie exercises are ranked quite highly among these modalities. And if these are initially administered in a supervised programs, they can really be more beneficial. So, what are basically Pilates? These are a low impact mind body exercises. And that's the good thing I like about it. They are like for chronic pain, anything that has to do with mind and body works in a good sync with the biopsychosocial model of care. It was developed by Joseph Pilates. Who's a military man, to just strengthen his platoon. So basically, it focuses on core strength, the powerhouse muscles, your deep abdominal muscles, your psoas, your pelvic floor muscles, your multifidus muscles. These movements are done in a controlled fashion, hence effective for fear avoidance. It improves your spinal alignment and postural control, and hence decreases risk of re-injury. And it's well coordinated with your breath work, which kind of works. It kind of works in down regulating your overactive stress response that comes as a bystander with chronic pain. And it focuses on movement efficiency rather than force. But uh, so that same core stability, breathing movement, these are low impact and they're hence more adherence in chronic pain population, but they're not very helpful for an acute pain situation when the patients are in acute pain. You need something along with medication or intervention that can help them for acute pain condition. Before jumping to that, the kind of Pilates would be the mat one, the reformers one with the machine, and the rehabilitation one, which can be done under the guidance of a physiotherapist. So the take-home message for Pilates, it's not just an exercise, it's a motor control therapy. Helpful for mechanical, non-specific lower back pain, helpful for postural and deconditioning, improving fear avoidance. They patients do great when they're combined with pain education, also providing like sleep optimization, stress management, activity coaching, helps in the chronic pain situation. Um, but they are not very helpful when you're having an acute pain, acute back pain. And for that, I see the McKenzie therapy can be a beneficial tool. That's why a combination of McKenzie and Pilates can be quite beneficial. So McKenzie exercises are part of mechanical diagnosis and therapy, which were developed by a physiotherapist, Robin McKenzie. So they are based on directional preference. So when we see our patients for back pain, we ask them, do you have flexion focused pain or extension focused pain? And then we try to differentiate based on their directional preference, whether the pain is coming from the disc or the facetogenic, mechanical, non-mechanical component, and also getting an idea whether they're having a radicular pattern pain, which is a classic dermatomal pattern, or a referred pain, the pain going from back to the posterior thigh, the anterior thigh, or the glutes area. So this McKenzie therapy is slightly similar, but slightly different from this evaluation. That first of all, we try to understand their peripheralization of the pain, where it is referring to, not radiating, but where it is referring to the gluteal area or to the posterior thigh. And then we repeat the activities that helps in centralizing their pain. For example, if with constant flexion or constant extension, they're centralizing their pain from the glutes to the lower back, and eventually um, the pain becoming less profound. That kind of gives you an idea to choose extension and flexion based McKenzie therapy. Most commonly, you will notice the patient will have pain relief on various extension postures, but it can vary. It can be in any direction. So the core principle is that you repeat a certain activity that centralizes their pain, and not only centralizes, but it also reduces their pain. And after you have differentiated that, then you give them flexion focus or extension focus exercises. And these are very simple to do home exercises, which could be done on a daily basis when they're having acute pain, because their biggest advantage would be um, for rapid symptom modification. And they're great for flare control, either it is discogenic, mechanical. You do not require any equipment. They're patient driven. Um, so they are, of course, less effective when we do not have a mechanical component or when we are not able to identify a directional preference. Um, and coming back, why should we combine Pilates and McKenzie? So McKenzie would be for symptom modulation during the initial phase, and Pilates would be for movement restoration. And we can give a prescription to our patients for 4 to 6 weeks, along with, physiotherapy referral. But this is something we can empower the patient right in the clinic after you have done an evaluation for back pain. So just quickly summarizing, Pilates focus on isometric contraction, improve your posture. McKenzie involves repeated directional movement exercise, like that involves repeated directional movement exercises. It improves postural training and it can help during the acute pain. There is good evidence to support the use of combined modalities of both Pilates and McKenzie. Um, so some of the key program that could be jotted down in a prescription format for our patient is we could advise them to, have it done under a supervision, either through a Pilates instructor or a physiotherapist. For Pilates, it is advised to do 1 to 2 sessions per week for 45 to 60 minutes. The program duration can go from 3 to 9 weeks, sometimes 12 weeks. So a simple prescription format could be McKenzie exercises daily for 5 to 10 minutes until their acute pain is settled down. They could slowly transition or start Pilates 2 to 3 times per week with ongoing education and pacing advice. So that would be the gist of physical therapy modalities that we could give in a prescription format. The third element that we could add would be a prescription to see a physiotherapist for more specific or exercises. So for our fellow, I think he did really well, but I forgot to mention one more. He also was divorced at that time, so going through some stressful phase. And I think there's also lack of purpose. So he also, met a girl and then got married, so got more motivated. But with incorporation of exercise therapy, I we did notice more functional improvement in 6 weeks. He has returned to full-time work by 3 months. He no longer drives Go Bus, so he's doing more of an office job, but he's working full-time. He has resumed recreational sports. He's back to playing basketball. He doesn't want to play ice hockey anymore, but overall he feels confident, feels empowered, and he's doing well. He does get back flare up on and off, but mostly he self-manages with the combination of McKenzie and Pilates. He had some hesitancy in joining Pilates because initially was an impression that it's mostly, female focused therapy. But I think there is like my wife goes to a Pilates class and she tells me there is a good balance of equal gender for that. So that this was this case. I think we have time to go to the second one, right? Maybe we can do the second one. Okay. So just take a message for the back pain. It's a biopsychosocial approach. It's the way to go for chronic lower back pain. This is more for mechanical with or without sensitization. But when we see a chronic lower back pain, the sensitizing features do kick in. Exercise is the first line therapy. Pilates and McKenzie can offer complementary benefits. So let's quickly jump to the next case. So this is a case on fibromyalgia and chronic migraine. Um, Learning objectives again would be to find the fibromyalgia migraine overlap and how various lifestyle modalities can be beneficial for both. As you could appreciate, you will see a lot of patients with fibromyalgia with chronic headaches with both tension and migraine type features. These patients also suffer from chronic fatigue, which is I find it more difficult to treat in my practice. Pain, you could still give medications, do shots, things like that. But with fatigue, I find the utmost challenge. Then we'll review some evidence-based non-pharmacological options that I'm trying to incorporate in my fibromyalgia patients. And also we'll see if we can put them in a practical prescription frameworks to just improve compliance and adherence to the patients. So there is a high comorbidity between fibromyalgia and migraines. Fibromyalgia has been a very challenging and questionable diagnosis back from the ages, to be labeled as neurasthenia, to be labeled as all in your head. And I've had discussions with many of my colleagues who never believed in fibromyalgia. I used to be one of them as well, but these patients will have various variety of symptoms, and they will have significant distress, both emotional, functional, and economic secondary to that. And medications are often insufficient, and I feel the medications only help for 30 to 40%. And the fibromyalgia can vary from severity. So I find the best model of care for fibromyalgia is the multimodal lifestyle interventions and mindfulness-based approaches, which helps to cultivate acceptance and more understanding in this chronic pain condition. So, this is a story about a 35 years old teacher who had a known history of fibromyalgia, which was diagnosed by her rheumatologist a few years ago when she was initially seen by the rheumatologist to rule out an autoimmune um, etiology of her constellation of symptoms she had at that time. So the autoimmune workup came back to be negative, and based on the 2016 American College of Rheumatology criteria, she was diagnosed with fibromyalgia. She had the whole gamut symptoms of widespread pain, chronic headaches with both migraine and tension type features, sleep irregularities, and fatigue. And these patients will also complain of brain fog or, medically speaking, cognitive dysfunction. Um, However, she was quite she was quite motivated. She was engaging in regular tennis and yoga. She watched her diet. She also was started on Cymbalta 30 milligrams, which she found to be beneficial to some extent for pain and fatigue. So she was able to work full time as a teacher, and then she will have occasional flare ups. And this is something I never believed, but most of my patients, when there is a barometric changes, they will complain of their pain getting worse. Um, and sometimes viral infections, life stressors, lack of sleep, that could put their fibromyalgia in a slightly overdrive than their baseline pain. So what happened with her? She was involved in a motor vehicle accident a few months ago. It was a low impact accident. It was a whiplash kind of an injury. Um, she did not had any significant trauma or significant head injury, but since the accident, she started reporting increased pain with increased severity of migraines to an extent that it was interfering with her daily routine. She was having um, challenges to work and had to go part time. So when she was referred to us, we started my main focus was on the migraine first because that was a presenting complaint. So after having an abortive regimen for her, and um, after understanding the severity of her migraine and being chronic and having more than 15 headache days per month, with 8 of them being migraines and having an impact on her daily routine, we decided to jump to preventative treatment. So my go-to drug has been topiramate because it's some weight neutral, but there has been some of the neurologists are lately preferring candesartan if the blood pressure is tolerable. So she was trialed on topiramate and candesartan, which had a suboptimal response. I referred her to one of my neurology colleague who tried the anti-CRGP, monoclonal antibodies. So she was initially trialed on a Jovi, not effective, and then was recently started on Emgality. And the neurologist was also considering Vyapti, which is an intravenous, if Emgality was not effective, but she was beginning to notice some response. During the whole process, I would see her for some headache-related interventions. I would perform some myofascial blocks around her supraspinatus trapezius, paracervical, greater occipital nerve, and auriculotemporal nerve, which I find quite beneficial for patients, but they don't last very long. But if patients get positive response, then I advise them to do a trial of Botox treatment if they've failed um, to preventative medications. So but there's one thing that came up during one of our interview, and I had seen her for a few months, and she never brought that up. Since the accident, she was also having a lot of emotional symptoms, and I do have a colleague in my clinic who does some meditations and counseling, and so she discussed that with her that in the she has some reoccurrence of her prior physical and sexual abuse that she had with her uncle a while ago, and that was not, and that seems to be bothering her lately with the whole spectrum of pain, fatigue, and migraines. And the reason I brought that up just to put into context for the biopsychosocial model, but most recently, because of the whole spectrum of symptoms, she was having functional impact, working part-time only, which was affecting her financial and was adding psychosocial stress. She was unable to play tennis. Um, There was pain-related distress and anxiety from what's going on, possible PTSD history, and so these could be the important modifiers for pain outcomes. Um, Again, reiterating on the biopsychosocial model of care. So if I have to summarize our key diagnosis, there is a chronic pain condition which puts her under a nausea-plastic or sensitization form of pain category. And then you combine that with worsening headache with migraine and tension type features. Because of her symptoms of fatigue, anxiety, um, and sleep irregularities, I think it was reasonable to put her under the spectrum of chronic pain syndrome and possibility of PTSD and anxiety. So this is all these is a kind of a recipe for that central sensitization model when you have no nociceptive or a true neuropathic injury, but your pain pathway from the ascending to the spinothalamic to the brain areas and then the descending pathway, there's overamplification. When you see this overamplification, you will also see an autonomic dysregulation, or in a simple language, that these patients are in chronic stress, chronic flight and fight state, and this all leads to that ongoing propagation of her pain condition and associated disability and distress that comes with it. So the management philosophy for these patients, if I focus on the non-interventional and non-pharmacological, would be educational reassurance, multidisciplinary treatment, and then patient-centered goal setting. Um, so just quickly brushing on the pharmacological interventionals for her, I did increase the Cymbalta. I also did a night dose of pregabalin. Um, and I didn't initiate that earlier because she was already on topiramate. I sometimes use off-label use of low-dose naltrexone, which I find in selective fibromyalgia patients for fatigue and chronic pain, but mostly for fatigue. Um, after she was getting some short-term relief from myofascial blocks, we also initiated a trial of Botox treatment for migraines, which I think was helping to some extent. But again, we were not able to address the ongoing psychosocial drivers of pain. So some of the non-pharmacological interventions that I find beneficial for these kind of patients is something that has the essence of mind and body. And so the four of my go-to or my favorite has been the Tai Chi, gentle yoga, aquatic exercises, and mindfulness-based therapy. So quickly jumping on Tai Chi, this is a low impact mind body exercises which has its roots from Chinese martial arts, and it is characterized by slow bodily movement with well coordinated with breath and focused attention. So it's kind of a even a simple word, it's a meditation in motion. So it basically helps to down regulate that stress response and helps to balance that yin and yang in the Chinese concept of the active and the, the passive energies. So it improves your central pain modulation by down regulating that overactive pain pathway. It reduces sympathetic overactivity. It helps to enhance balance because it's a rhythmic movement. So sleep, mood, and fatigue improvement, and there has been good benefits in fibromyalgia pain with improved quality of life. It can help in migraine through stress reduction and autonomic regulation. There is good evidence on the same with the study published in New England Journal of Medicine that noticed improvement in both pain and fatigue, um, which was sustained at 24 weeks. After 24 weeks, there was a plateau hit, but I think it was the improvement was up to 30 to 35%, which can be significant and relevant for these patients. A sample prescription for Tai Chi could be for 20 to 30 minutes, 2 to 3 times weekly, and 8 to 12 weeks. But if some of my patients who choose to do Tai Chi, I encourage them to do them as a daily practice. This is mostly for a guidance and structured program, but once they are comfortable doing basic movements at home, then they can do it every day for 5 minutes or 10 minutes. The second go-to modality is gentle yoga. So yoga in the Western or in the current era is seen as mats and movements, but yoga has its essence that goes way beyond that. Technically, yoga has 8 limbs, which includes, breath work, movements, positive attention. But for the sake of simplicity, um, I think gentle yoga kind of summarizes the principles of breath work and slow supported postures. The yoga word itself means union of body and mind. So again, it's a very powerful mind and body exercises, which cultivates relaxation, which cultivates, which downregulates the sympathetic response. Similar to Tai Chi, it reduces muscle tension because of that stretching aspect of it. And because of that breathwork and mind body aspect, it can downregulate central sensitization. So I do use medication like ketamine for central sensitization. Like if I quickly jump to the central sensitization down-regulating medication, it would be ketamine, pregabalin, and some of the new Alzheimer drugs. But the most natural way of decreasing central sensitization would be meditation, Tai Chi, and yoga. It improves sleep quality and emotional regulation. It decreases migraine frequency and intensity while decreasing the tension in the neck shoulder region. Because you could imagine that there's tension in the neck and shoulder, it goes to the greater occipital and through from the greater occipital to the auriculotemporal area, and then it activates the trigeminal cervical ganglion, which leads to that migraine propagation. Um, it encourages graded exposure to your movement. So yoga improves pain, fatigue, depression, and physical functioning, which can be sustained at 3 months and 6 months. Um, and then the thing that we have to consider about yoga is that because some of the yoga postures can be very stretchy and very overwhelming. So for these patients, I normally advise them to do low intensity, pain-free range only. Um, Duration can be 30 to 45 minutes per session, and similar to Tai Chi, 2 to 3 sessions per week. A duration of trial can be 8 to 12 weeks. And once they are more comfortable, they can do daily yoga practice at home, which could be self-driven, self-directed. Um, Aquafit, this is also one of my favorite recommendation for exercises, especially for our elderly folks. It involves structured exercises in warm water, um, using buoyancy and resistance to reduce joint and soft tissue load. Uh, the water itself decreases mechanical pain. The warmth helps in muscle relaxation. Water is therapeutic. There is, 70% of our body is water. Um, the earth is water, so water has a huge impact on our human evolution and psyche. So it's I think it's quite therapeutic. It's an excellent option for patients with exercise tolerance. Especially patients with obesity, for osteoarthritis flare up. And I think the water itself can have an indirect benefit in migraines with pain and stress reduction. There is again good evidence, again for Aquafit, 1 to 2 weekly sessions for 12 to 16 weeks. Um, so that would be some of the exercise the exercise therapy, which has a huge mind and body impact. But if I have to put them under one blanket, would be mindfulness. So these all could come under mindfulness, and I believe that mindfulness can be very beneficial for all of us in the chronic stress state we all are in, but especially for our patients in chronic pain. So, what basically is mindfulness? So, as per John Kabat-Zinn, he's the introducer of mindfulness in the Western world, which is inspired from Buddhist principles. And I think he started the mindfulness-based stress reduction program in Massachusetts. So, as per him, and rightfully said by him, that mindfulness is an awareness that comes by paying attention on purpose in present in a non-judgmental way. So most of the time, the pain patients are are havocked by the judgment from their family members, from healthcare providers, and also self-judgment. So mindfulness, by teaching them to have a sense of acceptance, letting it be and having a non-judging attitude can just unlock those or down regulate those chronically activated stress response. It also teaches us an awareness to be just present, not being worrying about what happened in the past and not worrying too much about the future, which is very difficult, but something that could just ground us in the moment. And that awareness that comes in that moment can be very helpful, both for the prescriber and for the patient itself. So some of the helpful modalities in chronic pain, breathwork is this is my go-to. Um, I use breathwork every time we do interventions for the patients. I find it very beneficial. Body scan, this can come in the form of a meditation format. It just helps you to be more aware of the body and what body could be the most bothersome. And then by inviting it or by addressing that area of the body which is causing discomfort, because it's an awareness, and then it could lead to the first step to any modality would be an awareness. So that could be helpful. Then mindfulness of just regulating your emotions and thoughts. What you thought becomes your emotions, and hence that further acts becomes your action, and the whole vicious cycle. Good actions lead to good thoughts, and bad actions lead to bad thoughts. So mindful movements and yoga and Tai Chi come under those modalities as well. So how these modalities work, they modulate central pain pathways. So again, down-regulate that central sensitization, sympathetic overactivity is down-regulated, and it just gives you more self-awareness and self-efficacy, which could be very enlightening. I took this course from Dr. Jackie Gardner-Nix. She runs this mindfulness-based chronic pain management course at Neuronova Center. Um, so she also enrolls patients, and she has become more creative after COVID because of online courses. So basically, the key points of this course, it's a 12 to 13 weekly sessions. It teaches various forms of mindfulness and meditation, which increases self-awareness, self-care, and emotional regulation and compassion. And the main purpose is not to, again, get rid of the pain, which sometimes might be difficult, but it's to reduce suffering, improve quality of life, and support sustainable pain management. In a nutshell, it helps you to live with pain in a graceful way and not, you know, not getting drowned in the pain-centered way of living rather than shifting focus to function-centered life. However, before mindfulness, you have to be careful for trauma history because it can lead to trauma awareness. And if someone is not trained for trauma sensitivity, the trauma awareness can be very distressing for the patient. Um, I think you have to pace the course based on patients, as per patients' expectations. And sometimes these patients will benefit from psychiatrist or psychotherapist support. Sample prescription for mindfulness, 5 to 10 minutes daily, progress to 20 minutes. There are some guided meditations that are available in various apps that could be given to patients. Quickly coming back to our case, so we incorporated Tai Chi. She registered with one of my colleague in the community who runs the mindfulness-based chronic pain management course, and she did notice improvement. I think it was a combination of everything, but 40% reduction in migraine severity. That was 3 months after improved pain interference. She's complaining of she's noticing some improved fatigue and sleep quality. She's really enjoying Tai Chi. Even her husband is doing it. Um, she has almost returned to work full time, but with some restrictions. For example, she would uh, um, she would regulate the noise around it, and she would be given more frequent breaks for now. She's loving breath work. This is my best modality that I personally practice and preach. And she's hopeful to join Cedar Springs or tennis club soon. So key takeaway, non-pharmacological therapies are core treatment for patients with fibromyalgia and migraine, and with when you expect those central sensitization pathway or overactivated stress response. Prescription given like medications can have a much more stronger impact. A lot of reinforcement during regular visits. These are some of the references. These are some of the resources for back pain. This is an app I like. It's curable. It has a lot of meditation, a lot of educational for chronic pain. Migrant Canada is a good resource. TapMy is a very good resource, slightly better than Michael D. Groot website. And then the mindfulness-based chronic pain management is run either at Neuronova. I think Dr. Amy Alexander, she runs a lot of courses and her patients just, sorry, I mispronounced her spelling. A lot of her patients love her. And then Dr. Zitney in Mississauga also run these mindfulness-based courses. I hope I didn't went over time. Thank you for patiently listening, and I hope we have some time for questions.
Thank you so much, Dr. Gumber. That was excellent. Really enjoyed your expertise and the very practical presentation that helped deepen our understanding of chronic pain and how to address it in ways that go beyond medications. So we do have a few minutes. We'll try to get to a few questions if anyone does have any questions.
I don't know if you can see my hand,
Yes, I
Dr.
do.
Patel. I was
Sorry,
just wondering, within your presentation, those were excellent resources that you had links to. And I was just wondering if you'd be able to send those along in terms of a separate email, because when we do intend to post this, I think that those would be very valuable
Yes,
to include in the update.
definitely. No, I'll definitely send us an email, and I'll also attach 3 books that I normally recommend to my patients with chronic pain. That could be very beneficial as well. Yeah.
Amazing. Any other questions?
And I just wanted to encourage everybody to, if they can take a look at the chat as part of our lifestyle medicine webinar series, we are doing an evaluation. So it's only 2 minutes of your time. So I hope that you can link in the chat and send us your feedback.
Thanks, Sarah. Chris.
Thank you very much, Dr. Gumber. That was excellent talk. Thanks for doing the presentation. With respect to the exercise therapies, the McKenzie and Pilates, are there places locally that you refer people to, or do you recommend that patients look for their own favorite Pilates studio?
Yes, so I think I normally start with them, the favorite Pilates studios. But in one of the clinic, we have a physiotherapist who would give them brief introduction on both of these exercises. So she can do initial assessment. But some of the patients who are not from the area, then I would just refer them to go to their favorite Pilates studio. For McKenzie, because sometimes physiotherapists can do a much more dedicated evaluation than myself. So I advise them to see a physiotherapist for 1 or 2 sessions and then carry on from there. Yeah.
Thanks very much.
Yeah.
And then there's a question in the chat about Nabalone and using it for chronic pain.
So yes, so Nebalon has been beneficial as a synthetic THC. It helps in sleep optimization as well, but it's not my first line agent for chronic pain. I would, if they have failed 2 agents such as SNRI or gabapentinoids, then we could consider Nebalon. I'm also very cautious in using Nebalon with elderly patients as it has slightly more adverse effects profile. But yes, it can be a helpful add-on for some patients, especially in helping for their sleep and pain at the same time. But my first go-to drug would be pregabalin, because pregabalin will help for chronic pain, some anxiety management. It also has some drowsiness effects to help for sleep, and it has some preliminary evidence for decreasing central sensitization. Second would be amitriptyline, and then third would be the Nebalon.
Perfect. Chris, do you have another question or?
No, I just have a really sticky hand that won't lower. Sorry.
Amazing. If there's nothing else, I think that's it. Thank you again, Dr. Gumber, and thank you all for joining. Again, if you could kindly fill out the evaluation form before leaving, that would be wonderful. It's in the chat window. Your CME certificates will be emailed to you as well. And if you'd like to see if you'd like to see recordings for this webinar as well as previous webinars, I'm just going to send the link for CCHOHT's webpage, and we have them all posted at the bottom if you scroll down.
Perfect. Thank you so much, Nivi. Thank you so much, everyone, for listening. All right.
Thank you. Have a wonderful day, everyone.
Bye. Thanks.